Good afternoon from Hong Kong. This is Asia Society Hong Kong, our COVID update series. We're coming on to episode 41, and today we're really delighted to have back Professor Ivan Hong from, a really renowned doctor here in Hong Kong. Dr. Hong is convener of the Vaccine Committee of AESI and advisory panel of a COVID vaccine, also affiliated with the Queen Mary Hospital, as well as dual specialist in infectious diseases and gastroenterology and hepatology and he is also currently the fellow of Royal College of Physicians of London and Edinburgh. He's a clinician, a scientist, and he is really one of our renowned doctors here in Hong Kong. We're really delighted here that episode 41, where we bring back Professor Hong. But I remember it was exactly 2 years ago, in June 30th, 2020, when I first met Professor Hong in person here at Asia Society Hong Kong. And that was episode 18. And it was a very, very different situation than in Hong Kong. The numbers were very low. And in fact, Singapore had just gone through a spike. And we were really, I have to say, kind of congratulating ourselves here in Hong Kong, how things have changed in 2 years. And we're kind of coming on here in Hong Kong, tail end. I hope it is the tail end of our vaccine, our fifth coverage of the fifth cycle and whatever, and it is really or our fifth wave. And I'm going to really use this opportunity to ask Professor Hong. He has been a lot of updates about what's happening with this pandemic, and are we coming to an endemic. So before I get started, I think I already gave you the contact, but I'm going to hand it over directly to Professor Hong, who has a presentation to share with us, and then continue our discussion after the presentation. So Professor Hong, floor is yours.
Thanks very much, Alice, for inviting me back to the Asia Society update on COVID-19, and it's my real privilege to be here. As you said, the last time I was here was just more than 2 years ago. And of course, that was the beginning of the pandemic. And of course, 2 years now. And I think a lot of things have changed, including that, of course, we now have vaccine. We now have a very good antiviral. And that we are building up our hybrid immunity, which I will talk about this later on. So I'm going to share with you some PowerPoints to address some of the major issues concerning the COVID-19. And then, of course, we will follow by some Q&A afterwards.
Okay.
Okay, I believe all of you could see my PowerPoint.
Yeah.
So the title of my talk, of course, is now COVID-19 infection from pandemic to endemic, which I think will be, the case very, very soon. So this is the latest situation as of 2 days ago on the 9th of July, where there were more than 553 million cases, 6.3 million deaths worldwide, with the mortality rate gradually coming down from 2 years ago, like 3%, now to 1.1%. And of course, the actual number of cases is far higher than that, probably 2 or 3 times higher. And the same for the mortality. And the real mortality rate perhaps is much lower than 1%. We're thinking of something like 0.4 or 0.3%, which is just 2 or 3 times that of influenza. And it's going to come down further as we build up our hybrid immunity. So as of in July, we have a major spike worldwide at the beginning of this year. And that, of course, correlates with the emergence of the Omicron BA1, followed by BA2. And of course, the Omicron is first emerged from South Africa. And of course, now that from South Africa, they have the BA4 and the BA5 coming out. And we are seeing a gradual climbing up numbers as the major variants is now the dominant variants of the subvariants of the Omicron BA.2 is now gradually being replaced by the BA.5, which, however, the BA.2 will have some kind of immunity, which I'll explain later on in my subsequent slides. In terms of vaccination, of course, overall, there's a major number of vaccination. Majority of the developed countries have already received 2 doses or even 3 doses. And of course, the number of deaths is dropping quite rapidly, despite the fact that we have, a surge of new cases in many parts of the world. And this is a situation of Hong Kong. We have, of course, had a major outbreak of a pure Omicron BA.2 at the beginning of this year from one single case, which is an imported case, which unfortunately a lady who was infected towards the end of her quarantine period in the hotel by another patients returning from Nepal, and then of course cross-infected with BA.2, which subsequently she passed it on to her husband, and then to likely to more than 4 million people in Hong Kong, as projected by our School of Public Health. So we have a pure basically outbreak of Omicron BA.2. Majority of the population has been infected by BA.2, and then of course we have the so-called a rapid drop in the number of cases in April, and then in June, of course, now we have a gradual surge of cases now to around 3,000 cases a day. However, the important thing is not to look at the number of cases, but to look at the number of hospitalization and also severe cases. And of course, with the so-called hybrid immunity, meaning that after you've been vaccinated and then you have a minor infection, it is pretty robust in Hong Kong. And of course, even though we have a surge of cases, it's now so-called plateauing of 3,000 cases a day. And for hospitalization, although we have a double number of hospitalization from beginning of June now to beginning of July over a month, from 400 to 800 cases, in hospital right now. But we have very, very few severe cases. In fact, in Queen Mary Hospital, none of our cases is in ICU. And the good news is, of course, we have no mortality for the past 4 weeks in Queen Mary. So we have an increased number of new cases and also increased number of hospitalization, but we do not have an increase in severe cases, and it's currently posing no stress to the health system. And I think this is a very, very important signal, and of course is important in terms of from the health system perspective. Of course, the number of vaccination, we have close to 93% of first dose and 90% second dose. The third dose is still a lot to catch up. It's still around 65%. So hopefully we'll be able to push that to close to 80% over the next 2 months. And then, of course, we could wait until the end of the year to be vaccinated with the Omicron vaccine, which I'll talk about later on. Death, we have 9,000 death, majority from the 5th wave. Per million populations are just over 1,000 in Hong Kong. So we are doing not too bad, which we have a fewer mortality per million than US and UK, but higher than Singapore and Japan. Before that, of course, we have a much lower mortality, but unfortunately in the 5th wave, a lot of our basically elderly people living in OH home have not been vaccinated, and unfortunately they succumb because of the COVID infection. So you look at the current situation, basically the second half of last year is predominantly by the Delta strain, which is the green color. And then, of course, there's a rapid drop in the number of cases until that's replaced by the BA.1. There's a rapid surge of BA.1 towards the end of last year and the beginning of this year, and then quickly replaced by BA.2, and then now by BA.4 and BA.5. This is the situation in South Africa, and basically similar situation in the rest of the world. The good news, of course, is that there's only 3 mutations from the between the BA2 and the BA4 and BA5 that happens in the N-terminal and also at the receptor binding domain at the basically the site where the virus is attached to the ACE2 receptors in the human cell. And these are the mutation that, especially the L452R mutation, that characterize the BA4, BA5 subvariants. And if you look at the latest publication from the New England Journal of Medicine from the Israelis group, it basically show you very, very clearly that if you had 2 doses followed by a booster dose, there is a rise in neutralizing antibody. However, the antibody against the BA4, the BA5 is very low. It's significantly lower. Is around 300 in terms of neutralizing antibody titer, compared to around 900 against the BA1 or 800 against the BA2. The BA2.1, 2.1 is also slightly lower, but is still sufficient in terms of protection. However, if you have 3 doses of the vaccine, or 2 doses of the vaccine followed by an infection of the BA2, you have a very, very high antibody, close to 2,000 against the BA2, 1,700 against the BA1, 11,000 against the wild type, and then close to 600 against the BA4 and BA5. So that means that if you had 2 or 3 doses of vaccination followed by an infection, this provides the very, very robust immunity. And this is called hybrid immunity. And this is probably something that we should be aiming at towards the, transforming from pandemic to endemic. And of course, this has been shown before the pathogenesis model that for COVID-19, of course, Omicron, there's a 2 or 3 days incubation, followed by 7 days of infection, of viral surge, followed by a overlapped hyperinflammatory phase. And the reason why we want to treat patients very early on with an early diagnosis is to suppress the viral load and hence able to suppress the inflammatory response or the hyperinflammatory phase that happens in the second week. And this is very important, basic for the pathogenesis of COVID and also form the treatment strategy. So treatment, of course, our principles, very, very early on, we're aiming at an early commencement of antiviral, especially for the high-risk population in elderly, in patients with chronic illnesses. And by a combination of the antiviral, you're able to increase the spectrum of activity and increase the potency and result in lower resistance rate. And by doing so, we were able to suppress viral load very early on, and hence we're able to reduce the chance of cytokine dysregulation, cytopathic damage, bacterial co-infection, and complication and death in COVID-19. And this is the antiviral mechanism of the oral antiviral that we have, and also the vaccine. The reason why we give the vaccine or we give the monoclonal antibody treatment is to basically have an antibody that blocks the receptors of the COVID to the ACE2 receptors. Okay, so this is very important, and it's the principle of the monoclonal antibody treatment and also the COVID-19 vaccine, by having an antibody blocking the attachment of the virus to the human cell. The oral antiviral, including the very potent Paxlovid, which is a protease inhibitors, and also the polymerase inhibitors of the molnupiravir and the remdesivir, is also very important by suppressing the protein formation or the viral RNA formation. So this, again, is very, very important for the treatment in early or high-risk elderly individuals. Of course, the early treatment we did is a triple combination before the Paxlovid or the molnupiravir becomes available. And this, of course, was published in 2020 in the Lancet, where we did a combination of interferon beta-1b, Kaletra, and ribavirin, and it works very well because of the combination, and able to prevent mortality and complication and suppress the viral load in high-risk individual by an early treatment. Subsequent treatment, of course, now using the monoclonal antibody is a combination, again, it's a combination of antibody that works, including the ASHK, which is a combination of taciguisadin together with selgivimin. So basically, it's a combination of two monoclonal antibody. It doesn't work on its own. It's got resistant if you just give one single antibody, but if you combine the two, it's able to work very well against the BA1 and the BA2. And this is important treatment for those who fail to mount an antibody response despite receiving 2 or 3 doses of vaccination. And these are individuals who are on chemotherapy, on B-cell depleting agent, for post-stem cell transplant individual, post-renal transplant individual, and for treatment of lymphoma patient. And this is very important for prevention of the COVID-19 infection, and also have some therapeutic use as well. And this is, of course, the study of giving the intramuscular monoclonal antibody combination, and is able to prevent significantly about 70% of these patients from subsequently getting infected. For the oral antiviral treatment, of course, the molnupiravir was the first to come to Hong Kong and had been given quite extensively in the 5th wave, and it's been shown that it's able to reduce the so-called severe infection and mortality by about 30%. But it has to be given within 5 days from symptom onset and better within 3 days. So the earlier you give it, the better the response will be. For the Paxlovid, which is nitramavir, ritonavir, again, is a very, very potent antiviral. And again, if you're able to give it within 5 days, it's able to reduce mortality and severe case by 80%. If you give it within 3 days, the protection or the prevention goes up to 90% in terms of hospitalization and also against death. So this is extremely important, is the early diagnosis and to give this oral antiviral very early on to our patient. And it's very, very effective, especially the earlier you give it. And of course, we have these two drugs, the Paxlovid, the nitramavir, ritonavir, and also the molnupiravir in Hong Kong. And this is given to our patient, especially elderly patient above the age of 60, and those with chronic illness below the age of 60, as our hospital authority designated clinic. For vaccine, I won't go through this again, but basically, there are the mRNA vaccine, there's the adenovirus vaccine, there's the inactivated vaccine, and there's also the recombinant protein vaccine. And in Hong Kong right now, we have the BioNTech mRNA vaccine, as well as the inactivated CoronaVac vaccine. And study from our School of Public Health have shown that very clearly that if you receive 2 or 3 doses, especially with 3 doses of the BioNTech or the Sinovac vaccine, you have a very, very good protection, regardless of the platform that you receive, mRNA or inactivated. You have a more than 98% if you receive 3 doses above the age of 60 against severe infection and mortality. Between age of 20 and 60, again, around 99%. If you for severe case and these fatal disease above the age of 60, 3 doses, 90% protection. If you have 2 doses, is lower, is around 80%, 72% for Sinovac, 90% for BioNTech. But if you're younger, it's around more than 90% for those, and more than 90% for 3 doses. Against mild to moderate disease is much lower. That means that against infection, much lower for Sinovac is around 40%. For BioNTech, it's about 60-70% if you receive 3 doses. 2 doses is around 20% for Sinovac, 30% for BioNTech. So it's not very good for protecting transmission for both platforms, but against severe disease and against mortality is more than adequate if you receive 2 or 3 doses, better with 3 doses of the vaccine. As I've said, very, very important is the hybrid immunity. So if you had 2 or 3 doses of the vaccine plus a recovery, that means that you have been infected, it will give rise to a very, very robust immunity. Of course, it has a very prolonged T-cell response as well. That means that it has a very good memory. That means with 2 vaccination, 2 dose or 3 dose vaccination, plus the infection. It gives you a very, very robust hybrid immunity. And that's probably something that we will be aiming at, and most countries will be aiming at, to form a good hybrid immunity to prevent further infection, or even if you get it, the infection will be much less severe. In terms of the very young, of course, that the FDA and also the CDC has already approved the use of this pediatric dosage vaccine for 6 months to 5 years old. Basically, those about 5 have been given, 5 to 11 have been given 1/3 the dosage. For those between the age of 6 months to 5 years, that will be given 1/10 the dosage of the adult dose. But the important, of course, it's very difficult to find this formula. It's very difficult to make a order, and we won't be able to titrate in 1/10. We need this special formula. So hopefully we'll be able to get hold of this vaccine in Hong Kong so that we can give it to our very, very young to cover the so-called immunity in these very, very young children. Of course, we have been testing the Omicron match vaccine, and that include we are testing the Sinopharm clinical trial for the Omicron match vaccine at HKU Clinical Trial Center for the Sinopharm and also for the Sinovac. And of course, the Pfizer and the BioNTech are already using the Omicron adapted COVID-19 vaccine, and it's proven in the interim result, showing that it offers good protection against the BA4, BA5, despite the antigens BA1. And the same for the inactivated vaccine. And Sinopharm, we're using the BA1, but hopefully we will be able to complete our study in 2 months, and we'll have some results to share by the end of October. And hopefully we will be able to use this vaccine or the BioNTech Moderna vaccine, mRNA vaccine. So our people in Hong Kong would have a choice of mRNA or inactivated vaccine with the Omicron adapted COVID-19 vaccine. That hopefully will be able to boost the antibody much better than using the first generation vaccine. So conclusion, looking ahead from pandemic to endemic, I think we are in a very good situation and very optimistic situation that we are fulfilling the criteria that allow the world to move from COVID-19 pandemic to endemic. The reason for this is because it's a widespread infection of mild disease with the Omicron, which is becoming much and much more flu-like, and also a very, very good natural or hybrid immunity achieved by infection and the high vaccination rate. We also have very, very effective oral antiviral treatment, and for the very high risk, for the elderly and those who have chronic illnesses. Important, of course, is the rapid diagnosis that allows early treatment is essential for the antiviral treatment to work. We also have will have a second generation Omicron match vaccine that are currently under clinical trials and should be able to be used towards the end of the year. So in the coming winter, very, very important, we need the annual COVID-19 as well as the flu vaccination. Don't forget about the flu vaccination. As we're talking right now in Australia, they have a very high surge of flu cases, especially among the pediatric patient, the young people and children. And so we need the flu vaccination as well as the COVID-19 vaccination to prevent a co-infection in our population in the wintertime. Face masking is very, very important, especially indoor, which will prevent both COVID, flu, and other respiratory viral illnesses. We also hope to have some kind of intranasal COVID-19 or flu combined vaccine that will be able to give rise to a very good mucosal IgA protection to stop transmission. And this, of course, will be able to achieve by hybrid immunity, where you have 2 or 3 doses of the vaccine followed by a mild infection. And this hopefully will be our way forward and allow us to basically transit from pandemic to endemic. So with this, I would like to end my talk. Thank you very much for your attention, and I will be very happy to answer any questions. Thank you.
Thank you. That was wonderful. That was kind of gave us a really great starting point. And I'm going to have some questions. And I know questions are already coming in from Slido from our online audience. And I think I want to start off, first of all, Professor Hong, thank you again for joining us. And I was rewatching our talk from almost exactly 2 years ago. And one of the things that you talked about 2 years ago was really the fast treatment, the antivirals. Is the treatment still about the same as 2 years ago, or has that changed quite a bit in this 2 years since the onset of the variants, the different variants?
The principle is still the same. So basically, early diagnosis and early treatment, that hasn't changed for the past 2 years. It's still the principle for treatment of COVID as well as influenza or other respiratory viral illness. In terms of the drugs of choice, of course, there's much more choices that we have right now compared to 2 years ago. And 2 years ago, basically, we're using repurposing antiviral, meaning that we're using interferon beta 1b and also using some other oral antiviral that works, including remdesivir, which is also given intravenously. And of course, the interferon was given subcutaneously. But now, of course, we have some very potent antiviral, as I've illustrated, with the intramediate ritonavir, which is the Paxlovid, as well as the molnupiravir, and we also have the monoclonal antibody, which is 2 injection in the buttocks of the Evusheld. It works very well. So basically, we have much more wide choices, and also we have oral antiviral agent that could be given as an outpatient rather than an inpatient. So we have far more choices, very potent antiviral, and the key is still that we give it early to make it work.
So right now, and compared to 2 years ago, I mean, it's also, I remember when you first hear about people getting it, it was almost kind of like not quite a death sentence, but people were very nervous about getting it. But now, I mean, to be honest, I have to say, many people around me and colleagues and people I know are getting it. And first thing they talk about is Paxlovid. So it's no longer this fear factor of when you like 2 years ago or even a year ago pre-vaccine. So things are better, I think. So there has been improvement, and also another thing that you mentioned is the drop in the mortality rate. I think 2 years ago when we started our conversation, I think the U.S. I think it was the beginning. You're seeing a lot of the some of the death in the elderly homes, and we unfortunately got it during the 5th wave. So I guess the question I have, and I think many of my friends have sent in question, and also reading the paper, is really the likelihood of the 6th wave. Would you characterize we're still in the tail end of the 5th wave, or are we part of the 6th wave? And if there is a 6th wave, what would be the conditions? When do you think we will see a 6th wave? And are you concerned?
We are at the tail of the 5th wave. So just to clarify, because we are still under the effect of the Omicron subvariants. So as long as you stay as an Omicron subvariants, we are still at the 5th wave. In fact, we do not touch 0 as of previous waves. So the lowest I remember, I think we were in at least a few hundreds, just below 1,000. And then, of course, it stay in 1,000, and then gradually there's a minor surge right now to around 3,000. And of course, we could use Singapore as an example as well, because Singapore is quite similar to Hong Kong. That they have now, of course, have removed most of the infection control measures, and that they relied on the hybrid immunity. And they have a very high first and second dose vaccination rate similar to Hong Kong, and they have an even better the 3rd dose. They are already up to around, I think, 70%,
Right.
where we're still at 60% for our 3rd dose. And basically, they have about 3,000 to 10,000 cases a day, but they have very few so-called cases in the ICU, which is similar to Hong Kong. So we have very few severe cases.
And
And I think that is very encouraging, meaning that they are basically they have cases diagnosed but they don't have or very few severe cases. So we are right now we are at the fifth wave. If you sixth wave, what we are looking at is basically if it's a completely new variant, okay, it's non-Omicron variant, then that may cause problem. That means that we had even though we have Omicron before, the immunity perhaps or hybrid immunity perhaps is not adequate against the new variants, and then we have a new surge of cases, probably back to like you know tens of 20, 30,000 a day, or even up to close to a million cases, then that will be a so-called a sixth wave. So right now we are not. It has to be a different variant, a completely different variant. But it's unlikely, given that if you have a new variant, the likelihood it will be even milder, more contagious compared to the Omicron.
And right now, my understanding is Singapore numbers are going quite high and predominantly BA point 0.5. And again, nothing serious in terms of there's numbers are spiking, but they are not as concerned, similar to here. And I believe the US is also predominantly BA point 0.5 now, and Europe as well. So even though the waves are, the variant numbers are going up, like you said, the severe cases are not like as we've seen it. And I guess one of the questions that I have right now is vaccine. Right now, you talked about the third doses, and in many places, they're already talking about the fourth dose, and even in Hong Kong now, you can get your second booster. And I got mine the other day because I'm going to be traveling. So and some people are saying they're waiting for the new vaccine, the new generation that's going to be coming up later on in the year that is targeting Omicron. So, what would your advice to people? People are waiting, yes or no on the fourth jab. What is your professional advice?
Yes, my advice to many of my friends is that if you had your third dose basically last year, towards the end of the last year, that means that you already 6 months since you have your last booster, then I would recommend you to get the fourth dose, because usually after 6 months there will be a quite significant drop in terms of the antibody response, and that will be able to boost your antibody. Especially if you're traveling, then they may give you a basically a short-term protection. The problem, of course, is that you're still receiving the first generation vaccine, which is based on the wild type original virus. So the protection will be very transient. We're talking about maybe just 2 months, 2 or 3 months of the boost of antibody level. But if you have your third dose sometimes in Feb or March, that means that it won't be 6 months until September and October. In that case, then I will advise you to wait, because the likelihood is that we will have a second generation Omicron match vaccine probably sometime in November and December, which will be available for vaccination. So I would suggest you to wait until towards the end of year before you have the fourth dose. But of course, if it's already more than 6 months, then you should get your fourth dose. If not, then you could wait a little bit longer.
But right now, you're working on this. Your trial already begun in June. So, is there any initial insight on the new generation of vaccine that you can share right now? Optimistic?
Yes, we are now testing. We're doing 2 clinical trials. One is a phase 3, one is a phase 2 for the Omicron match vaccine, which is an inactivated vaccine for the Sinopharm and the Sinovac. Basically, for the Sinopharm, we are recruiting 1,800 subjects, randomized in 3 arms. 2 of them will have the inactivated vaccine, Omicron match, and 1 of them will be on a so-called the original vaccine as a control. And the Sinovac is a smaller scale, like 300 subjects, but randomized into 1 or 2 doses of the Omicron match vaccine. So basically, we're still recruiting subjects. So if anyone would like to join, then definitely they should visit the HKU Clinical Trial Center site. They will have all the details there. But so far, for the Sinopharm, we have vaccinated more than 800 subjects, and so far it's very safe. So we have very few adverse effects, basically so-called none vaccine-related severe adverse effects, and it's very safe. So both platforms are very safe. The immunogenicity, we have to wait towards the end of the September when we complete the study. Then hopefully we'll have some interim results. We will be testing it against the BA2, BA1, BA2, BA4, and BA5, as well as the primitive viruses. And of course, we'll be looking at the clinical protection as well against infection.
In a few minutes, I know there's a lot of question here and already coming in about quarantine, and I know that's the hottest topic in Hong Kong now since we're still under the zero COVID and it's 7-day quarantine. But for one of the questions I kind of wanted to talk about is a bit lessons learned. When we started the series, February of 2020, a few weeks after the first cases started in Hong Kong. The idea was that here in Hong Kong, we have experts like yourself, who are veterans of SARS, and from 2003, and Hong Kong did really well the first, I would say, the first 2 years. It was only till the fifth wave. So one of the reasons was to Hong Kong lessons from Hong Kong, but obviously fifth wave hit us very hard. I think the mortality rate, the lack of vaccination for the senior population and the vulnerable really hurt us. And in fact, we still have one of the highest, rolling average mortality rate. I hope no one tops us on that number. But so what is our lessons learned from fifth wave? I mean, are we able to share that with, for example, across the border in mainland, where and as well as Taiwan? My understanding in talking to friends a couple of months ago was how low also Taiwan's vaccination rate and China's as well. So lessons learned for us. Are we able to share some of that information with across the border? And also, what are some of the lessons that we learned from Singapore? So those are the questions that I have for you. Lessons learned.
Very, very good question and very important questions of the lessons that we learned from the fifth wave. In fact, it was very upsetting that we have such a large number of very elderly people who unfortunately succumbed in the fifth wave, which could have been prevented, of course, if the government has really listened to us and they managed to start the vaccination visa much earlier, because we have proposed that in fact in October, in November, in putting the COVID-19 vaccine visa or the pass before Christmas, before this end of December, with 2 doses of the vaccine. But unfortunately, due to various reasons, it was subsequently postponed to be after Chinese New Year. And of course, it was already too late. And the fifth wave happened towards the end of January. So the first things that we learned is that if we have able to make or set up the visa and hopefully encourage or given the incentive to get most of the elderly people vaccinated towards the end of last year, a lot of the mortality could have been prevented. That's the first thing. Second thing, of course, is that we are, in terms of the mortality rate, we are in fact in the middle. Okay, we are not top. We are far away from the top. We probably rank around in terms of mortality, probably 50th or 60th, far lower than many Western countries. But of course, we are compared to Singapore and Japan, where they did really well, we are behind in terms of mortality. But mind you is that the mortality age for Hong Kong is very old. Okay, so the median age probably around 80 or towards 90 years old. And that is because we have many very, very elderly people. In fact, Hong Kong has the highest lifespan for both male and female. And this is, of course, sadly, the group of elderly people that came down in the fifth wave, especially those in the elderly homes. And these elderly people perhaps would have succumbed, if not as COVID, it will be influenza. So as I've said, the second lesson learned is not just vaccination for COVID, it's also influenza. So you need influenza and COVID vaccination before the end of this year to prevent death in the coming winter. Very, very important in the elderly, especially those above the age of 70. And these are lessons that we have learned. I think Singapore and Japan did very well in terms of vaccination, especially in Singapore. And you can see that basically with a very high vaccination rate and also some infection, what we call hybrid immunity, that is very robust. And I think now Hong Kong is very close to Singapore. And of course, we still have infection control measures in place. So we have fewer new cases compared to Singapore. But in terms of severe case, we are probably, and death, we are probably the same after the fifth wave. Across the border, we have shared, of course, this information with Professor Liang Manin, who is the chief of delegates from the Chinese CDC. And I think in the Chinese CDC and also in mainland, they also share the same view as us, that they have to really boost the vaccination rate among the elderly, which is currently still not very high, especially among the elderly. I think the below 60 is very high vaccination rate for 2 doses, probably close to 90%, similar to Hong Kong. But for the elderly, it's probably because there are a lot of concern of the side effect of the vaccine, as well as in China, they have been doing too well, very few cases. But this is probably, we could not be too complacent, because eventually there will be cases, and if it got hit, especially in the winter, in the elderly, then there would be a lot of very high mortality numbers, not rate, but numbers, because even 1% of the elderly population in China, we're talking about millions of people. So really have to get the vaccination rate up with 2, if not 3 doses. And then again, boosted by the Omicron match vaccine towards the end of the year. I think that applies to every single places in the world, not just Hong Kong or China or Taiwan or Singapore. I think this is very important.
I think what you point out is so interesting, complacency, because having done this program now 2+ years, every time we did a program of a country including Singapore, everybody was so patting ourselves on the back. Then something happened, and here in Hong Kong as well. And so I think hubris and complacency has no place in this global pandemic. And maybe this explains why China is still very, very concerned about the border and the tightening and a tightening of the border and people coming in, the zero COVID strategy for whatever reason, for their reasons. And you point out earlier in your presentation that it took one case of and in fact, the one case that really started the fifth wave. But then that also will lead me to the next part of the question. It's about the quarantine. That one case here in Hong Kong, she came in from, I believe it was Pakistan, and might have contracted during the period of quarantining. So how effective has been the quarantine policy? I know, for somebody who, like me, who had withstand 2 3-week quarantine last year, I understand the necessity of it. But how effective do you think the quarantine strategy has been in this here in Hong Kong this last almost 2 years?
Well, I think for quarantine, if we're talking about the beginning of the pandemic, okay, where there are no vaccine, no really effective targeting antiviral, then quarantine is very important. And I think this is actually able to prevent cases, prevent hospitalization and death and high, severe cases. But right now, if you have a very good vaccine as well as antiviral, then I think the role of the quarantine will be much lower, because already there are viruses circulating in your community, and the quarantine won't help very much in terms of the disease prevention or suppressing the number of severe cases. It won't help. More important, however, is, as I've said, vaccination as well as early diagnosis and antiviral treatment. That probably is more important than quarantine. And as I've said recently, I think the quarantine really could be replaced by a effective, so-called PCR. This probably could be done if you have a very quick turnaround PCR testing, and you can do a more frequent testing if you really want to, maybe daily testing, and then have an early diagnosis. Then if you are positive, then you can undergo a home quarantine. Plus that, if you are high risk, then you can take the oral antiviral treatment. I think that probably will be much effective in terms of treating early treatment for high-risk patients, preventing severe cases of hospitalization, as well as in certain ways lowering the so-called the transmission within the community, rather than doing the quarantine. As we've seen, even towards the end of the quarantine, you can still have cross-infection within the hotel, which unfortunately the air change in the hotel is not good enough, and you can still have cross-infection in the hotel.
I think we're hearing from the new Secretary of Health, Professor Lo Chung-mo, mention the testing, yesterday, I believe, and shortening the time of testing instead of 24 hours, making it and maybe 4 to 8 hours or something for the PCR test. And I think some of us, instead of quarantining, we're happy to do the PCR test whenever, just to present to not have to do quarantine. How likely do you think this will happen? Because when I see how fast Hong Kong has moved, whether it's the rat testing or the PCR test, things are very efficient here in Hong Kong. So, and then we're talking about the private sector getting the testing done. Are you optimistic that can happen quite fast?
Well, I think really we have to liaise and discuss with the basically with the various labs. I think probably I think around the range of 12 hours will be quite realistic in terms of the turnover. But I think 12 hours will be good enough if you are doing it daily at a fixed time every 12 hours for a 7 to 10 days. And I think a lot of people are very willing to do so, and allowing them to be exempted from the quarantine. So that means that they could go back home or go back to work immediately if they return to Hong Kong, and then they would go through a daily testing at a fixed time with a very quick report once or so-called tracking once you have been diagnosed with being positive, and then they could do a sequencing of the type of the variants or the subvariants. Then that will probably be very important, and that could hopefully replace the quarantine. As I've said, it is not very effective.
We have some question coming in the audience. This one I wanted to put to you. It says, does the hybrid immunity prevent infections, or does it just mean you don't get as sick? And how long does it last?
Studies basically for the hybrid immunity show that is not only able to protect severe disease or hospitalization, but also against infection. Because the importance, of course, getting the vaccine followed by a natural infection is that it offers a very good mucosal antibody. That means the IgA mucosal antibody that is found in your nostril, in the upper respiratory tract. That means that the virus could not attach to the cell and cause an infection. So the transmission will be able to prevent by this hybrid immunity. The hybrid immunity is much more robust. It will last, I think, at least around 1 year or even longer, because it got much more robust T cell response. Has been shown by some of the early studies that the T cell actually lasts much longer compared to the neutralizing antibody. So the memory cell actually lasts much longer. So the hybrid immunity is likely to be the way forward, as happening in many parts of the world.
My question is, what is the difference between the hybrid immunity, what you talked about, and the herd immunity? Earlier in COVID, we were talking about some of the doctors we talked to was trying to get 70% herd immunity. So, what is the percentage of hybrid immunity now, and compared to the what we talked about earlier, the herd
Basically,
immunity?
herd immunity is talking about you get people vaccinated. If you have high enough people getting vaccinated, it will be able to stop the transmission and also prevent against severe disease and deaths. But unfortunately, the COVID, especially the Omicron, is so immune escape that basically, and also the vaccine that we have offer a very poor mucosal antibody protection. That means that very, very low IgA antibody is found in the mucosa, on the nostril, or in the upper airway. So as a result, it could only protect against severe infection, and that you still get the infection but very mild or maybe asymptomatic. So the herd immunity currently, unfortunately, is not very high or almost close to none with the current vaccine in COVID. So this has now been so-called replaced or being replaced by the hybrid immunity. That means that you have the 2 or 3 doses of vaccine followed by an infection that will be able to offer you a much more robust mucosal antibody protection in your upper airway and your nostril, and hence you will be able to prevent the transmission of the infection. As you see here, basically, because we have in Hong Kong, we have majority of people have Omicron BA2, and hence we have some kind of hybrid immunity with the high vaccination rate. And you see that basically after like reaching 3,000, it starts to plateau. If you do not have the hybrid immunity, it will basically go rocketing high to maybe 10, 20, 30,000 cases a day.
So you don't think we're going to stick right now? It's been about the 3,000 range. It'll be around that range for how long do you think, or will it drop?
We could have turnover to after a month or so it could reach 6,000 to 7,000. But the encouraging news is perhaps that even though we have 7,000 to 8,000 cases a day, we will still have relatively few severe cases. You might have an increase in hospitalization to more than 1,000 cases a day in the hospital, but I don't think it will be too stressful to the hospital authority, and that of course it will not have many severe cases. Definitely not as bad as the fifth wave, and I think the hospital authority will be able to handle or to deal with the current number of cases of COVID.
This question from the audience is asking about the future of vaccines. Will I have to get a shot for every new variant?
Probably not the case. You probably will need to get a shot of the COVID, just like influenza every year. And then, of course, the WHO or the CDC will predict the next circulating strain. And then, of course, if they have the antigen, then we will be able to formulate the vaccine maybe in the middle of the year for the end of the year vaccination. So you will probably need a booster of COVID or the influenza every year before December, maybe October, November time. But you might not need to get every time you have a subvariant emerging, you don't need an extra booster, just like the Omicron. But you will need a booster every year.
This question is asking about the health code. I think we here in Hong Kong, yesterday was an announcement that the new government is considering implementing a health code, COVID health code similar to that in the mainland. Is that likely to happen, do you think?
We don't know yet because it's still a lot of logistic to go through. And I think that if you have the red or the green so-called signal, I think that is quite feasible. Is basically something that we've been doing already, but in a much more organized way, and of course it's much more efficient. But the problem, I think, is the amber signal. Okay, the amber signal is somewhere in between, and I think that if you use the amber signal as is in mainland, in Hong Kong, it will be very disruptive. The problem with the amber signal is that if you have someone in your building where you live confirmed to be a case, then your signal will turn into amber. That means that you can still go to work, but you will not be able to have access to public places or to restaurants. So in that case, that it will be very disruptive, because in Hong Kong we have blocks of buildings that people are living in the same block, perhaps 30th, 40th floor, and there will be hundreds of people living in the same block. So it will be quite easy to have one person confirmed cases, and then you have the whole building being changed into amber, and that could go on continuously, so for one after the other, and they will go on for 6 months. So for the next 6 months, you will not be able to access any public places. You won't be able to play sports. You won't be able to go to the restaurant, and then probably half the population in Hong Kong will be ending up like this. And then you basically have the restaurants will basically get run out of business, and I think that will be very disruptive. So I think really you have to go through the logistic. For the red and the green, there won't be any problem. It's something that is very clear cut. But the amber, really, I would suggest perhaps taking the amber signal away, a modified version of the mainland one. Otherwise, this will be a huge disruption to our daily life in Hong Kong.
One of the questions here is really, I think on everybody's mind, is how compatible are Hong Kong and mainland's COVID policy, COVID-19 policy, and what do you see the future in terms of reopening of the border for Hong Kong with mainland, or Hong Kong with the rest of the world?
Well, I think it's been highlighted by our new CE, Mr. Johnny. Basically, he has already said that there's a fine balance of the COVID infection control measures as well as the economy, and I think that he already said that if possible, he would basically trying to open the border, either internationally or with mainland or both, as quickly as possible, given that of course it will not be affecting the endemic situation or the pandemic situation in Hong Kong, and that whatever comes first, that he will be able to perhaps consider. So maybe we could open up the international border first, provided that it won't affect the current situation in Hong Kong in terms of the COVID outbreak. And of course, when mainland is ready, then of course, when we are ready, then we could of course open the border to mainland as well. But already we're seeing that the government are doing many things. They have already canceled the flight ban, which is
Right.
very important and an excellent move, very scientific. And then, of course, hopefully they will be able to shorten the quarantine and replacing it by daily PCR testing. And the same apply for mainland. Of course, they have increased the number of allowance for Hong Kong residents to go back to China, even though they still have to undergo certain quarantine measures when they return to Hong Kong, to Shenzhen. So these are the measures that I think the government are driving to you know recently. Uh, the other thing, of course, I believe is that the Hong Kong and China is gradually coming together, meaning that, of course, we are making fine tuning in terms of our reporting system, our PCR testing. I think China is doing the same, and both of us are now hoping to increase the vaccination rate among the elderly. And I think with that, when both sides are ready, and I think by then, I think that the border will be open to China. But I think that will still take some time for the policies to come together. But I'm optimistic.
Great. I'm going to wrap it up because I still have a lot of questions for you. I know how busy you are, and you have been man of the hour, and I've been so looking forward to talking to you. So I won't take too much of a time, but I kind of want to wrap up on, if you are concerned right now, like what are some of the things that are keeping you awake at night? We're, like you said, not over the fifth wave yet. We're tail end of it. But from your scientific, from your research, from you know more about this disease than most of us laymen's. But what are you, as a research, as a doctor, what are you worried about right now in the next, short term and long term?
I think my major concern is very much towards the end of the year. When the winter comes, and then of course coronavirus is much more active in colder weather, similar to influenza, and when we have a co-infection of COVID as well as influenza. And I think that is something that we really have to watch out for and to prevent. And that could be done by a very high vaccination rate with the booster of COVID as well as influenza, especially among the elderly population and also the pediatrics in the very young and the very old, as well as that we have to bring in the very effective antiviral treatment, oral treatment for influenza like balosavir, not just Tamiflu but balosavir, as well as the antiviral treatment for the COVID. So we have the oral antiviral stock up together with the very high vaccination rate, and then of course masking in the winter. I think we will be quite okay for the next to prevent the next wave in the coming winter.
Okay, last question, promise. Is really, you must know the new health minister, probably colleagues, and the government is only, 11 days old. July 1st was the swearing in new government, and you are on the co-convening role of, the vaccine, and you are definitely listened to by the government. So what are some of the things that you're advising the government to do in terms of short term and long term to get us out of this, still in this neverland? So what is your advice to the
Well, I
government?
think the expert panel, we have a consensus in terms of the hybrid immunity. I think the hybrid immunity is most important in terms of preventing, further outbreak or so-called like the surge of the fifth wave again, or even the next wave. It's a hybrid immunity, meaning that you need to really get up the vaccination rate among the elderly, especially the third dose. And then of course booster towards the end of the year with the new Omicron match vaccine when it's available. As well as that, of course, there will be some cases circulating in the community. And then I think that circulation, although it's a low-grade circulation, you don't want to have a really high numbers, but a low-grade circulation in the community is very important because that actually build up the hybrid immunity. Provided that, of course, there are relatively few severe cases, and that is right now the situation. So the hybrid immunity is the most important thing, is the backbone of the entire so-called defense or prevention for the next wave. But of course, the most important is the vaccination. That is something that we really want to get, is the high vaccination rate, the third dose in the elderly, and then later on the fourth dose.
Okay, I promise this is definitely the last one. But as you were talking, I wanted to ask you 2 years ago when we spoke, are you surprised at how long COVID has lasted?
Yes, yes, indeed. I was surprised because basically we were all thinking that it would end probably 12 to 18 months. That will be the end of the pandemic. But the Omicron or the COVID proven to be much smarter than we thought. It start or continues to emerge with the new variants and the subvariants, and the Omicron is getting smarter as well. It's very immune escape. So, but the good thing is that it's getting weaker and weaker. It's much more contagious, but it's getting more and more flu-like or influenza-like. Even though it's influenza-like, we still have to be very cautious because even with a mortality rate of 0.1%, it could be still a large number of patients dying. So once again, it's the vaccination that is most important and the antiviral treatment with early diagnosis with PCR.
Well, on that note, I want to thank you so much, and I really do look forward to having you back. I know Professor Ben Cowling has been with us 3 times, and you've been with us twice. Each time, I learn so much, and I think less fearful because what you have said each time the scientists have you point to the scientific research and the facts, and even if you get it, it's not fortunately for most of us, it's not really the death now. And so thank you for your really wonderful updated information, science-based, fact-based. And that was what this program was really about. It was never about politics of this disease. So a lot of countries have seen it evolve into it, but I'm really grateful to all of the scientists, the researchers, the doctors who have come on this program. And to be honest with you, when we started, with Ben Cowling in February of 2020, I really thought by year end, we would be over. And but we'll continue to bring programs like this. Our next program will be with Dean Michelle Williams of Harvard School, T.H. Chan School of Public Health, and Dean Williams is going to talk about the disparities, what showcase from COVID, and how each country is dealing with it. So I again thank you, Professor Hong. I really do look forward to having you back because every time you come back, you give us fact-based information that makes us feel better. It's not the end of the world. So thank you so much, and good luck with
Thank
your
you, Alice.
research and
My
with your
pleasure
vaccine.
to be here.
Really
And hopefully
appreciate it.
next time I will be talking something else rather than COVID.
Anytime you would like.
Thank
Anytime
you.
we'll like. Thank you so much. And thank you, those who joined us. And thank you for your question. And I really appreciate, our audience, which is now global. So we look forward to sharing more information about the situation developing here in Hong Kong and pretty soon maybe quarantine-free Hong Kong. So thank you. Thank you,
Thank
Professor
you.
Hong.
Goodbye.
And
Take
thank
care.
you.
Bye-bye.
Bye-bye.